Hey, this is Brandon. Going to go over the blog we had from last week on elbow pain. Obviously, it was mostly directed towards the lateral elbow pain, being our lateral epicondylosis and itis and those kind of things, even including things like pin syndrome and then getting into a little bit of radial tunnel syndrome. However, I want to cover three things that I don't think I did well in that blog that I do want to maybe highlight in this conversation here. And if you have any comments, concerns, I'll of course post them here or email me at any time. However, the first one was brought up by Michael Bracchio. Love this guy, respect this guy, does great work with the ACA. And his question, I think, really brought up one of the misnomers that we see when we do our talks, is that Dr. Berlesman and myself are big into tendinitis versus tendinosis. And a tendinitis is an acute inflammatory process. And that happens all the time in our body when we go over and above the capacity of any kind of a tissue, in this case, more of a tendon type tissue. However, what we know, what the literature says, what you know, is that goes away pretty fast, meaning 2 days, 3 days, that inflammatory process is gone. So we don't see those things a lot. And his thought was, to stop using the word tendinitis, and I tend to agree with him. The new word in the research is reactive tendinopathy. And I like that. It's a new term, so you'll be seeing that a lot more in the research and in our blogs. The second being what happens when it turns into a tendinosis. And that's more of a degenerative tendinopathy, meaning what's actually happening in that tendon. So that brings up a good point as far as knowing terminology. Not only knowing terminology when we talk to people around us or we talk at seminars, but also with medical doctors. When you talk to researchers and people that are on top of their game, they're going to know those terms. So, Michael, thanks for bringing it to our attention, and we'll try to make a change on our end. The second piece of that was actually included in one study, and that blog was not written and didn't end up like it was supposed to end up. In fact, I was just going to review one study, which was the Bassett study from 2006, because I think it highlighted a deficit in my practice. And that deficit is I use a lot of allopathic care on a regular basis for my patients. And I don't know if I should be doing that quite as much. And I do it for more networking. I think it's very important. However, I think I may use it a little too much, and I'm going to hopefully explain that hopefully in this conversation. But before I get to that, I want to cover just the tip of the Bassett study, which was the first part of the study when they said the people in the physiotherapy arm, people getting more rehab for their lateral epicondylopathy as compared to corticosteroid injections or a wait and see approach. And what I thought was so interesting in that paper is that those people sought less treatment. Meaning, I believe, and I don't know this to be true, but I think people in MSK care really care about educating their patients. And that's one thing that I want to highlight today, is that the more your patient understands their condition, and in fact, if your patients understood their condition just as well as you understood it, they'd get better. And the reason they'd get better is because they understood what it would take to get better. Like the second point in that blog was sleeping on the elbow. If someone understood that when they sleep is when they heal, and if you add compression to an area that's trying to heal, then they're going to stop doing it. It's no longer you asking them to sleep in a different position, but they're going to try to do things to help themselves. Most people don't want to be in pain. Some do, but most don't. And they're going to try anything possible to help get themselves out of pain. So please, educate your patients. If they know what to do, if they don't know what to do, and they still fail, if they know what to do and they still fail, it's on them. But if they know what to do and they're hopefully doing those things that you ask of them, and then they fail, then it's your fault. But it's our job to educate them on all those pieces of the puzzle. The last piece of this is where I really have changed the way I practice, and it has to do with corticosteroid injections. And I actually do use injections for a good number of my patients when I need a window of opportunity. There's a lot of people who need a little bit of pain relief, and I've always learned that a steroid, whether it's a Medrol dose pack or an injection, will help give them a window of opportunity. And I do believe that's still true, because in that study they found that 80% of those people who did have that steroid injection in their lateral elbow did have pain relief. Here's the problem, is that 62% of those had a reoccurrence. Meaning if it's not a degenerative condition, an acute situation, it's not an inflammatory condition, it's still going to provide pain relief, but that's going to limit inflammation, which is limit healing. So those people that would have been just perfectly fine with the wait and see model, 22% of them had to wait longer. It delayed their care because of that corticosteroid injection. So if you believe, if in your evaluation, in your history, that this is more of a degenerative model, this is more of a degenerative tendinopathy, a tendinosis model, then an injection is not going to help them. In fact, I would argue it's going to hurt them. It's going to delay their healing. While they may get some short-term relief, if you do your job and you educate them on the exact condition, the diagnosis and the prognosis, then I think you're doing yourself and your patients a favor. They're going to seek less care, they're going to get better faster, and most importantly, they're going to stay out of pain. I tell each and one of my patients, my job is to get you in and out of pain as fast as possible and then never see you again. And I really truly believe that, because if we do a great job at treating our patients, then hopefully we're not going to have to see them for that same condition. Do I want to see them for every other condition they have in the MSK arena? Absolutely, and hopefully that's why I build a practice where I will see patients lifelong, but not for the same condition, not for the same problem. It builds patients who are very loyal to us in our practice because they know that we're looking out for them. So in the world of steroids, do they work? Yes, they do help with pain and inflammation. However, for some conditions, it may be delaying their recovery. So make sure you're able to decipher which one of those two that patient needs, whether they need injection, need some help or not. And of course, an all-natural approach is beneficial compared to more of a foreign substance in the body. Just something to think about. The last piece of this is purely hearsay, purely my opinion. So I want to distinguish that from scientific fact. There may be scientific fact on it, but I'm not aware of it quite yet. And that I was having a conversation at a soccer field with a pain management doctor, interventional radiologist. And he talked about injections. And he looks at imaging all day long. And that's all he does, is looks at images and then sometimes is actually injecting the area. And I asked him about bursitis. When do you see a bursa that's actually inflamed? He said, well, I see inflammation all the time. It's all around the hip joint. I said, no. When do you see an actually inflamed bursa? And I was looking at more of the hip or the shoulder, and he said, you know what, I never see that. He said, I see the inflammation around the muscles and tendons. He's seeing that kind of inflammation. And he said, normally, by the time we do an injection, I really don't see any inflammation, and he still does injections. However, here's the cool part about that, is he said, it would be much more beneficial, not these PRP injections, not these other adjuvants to create stem cells and that kind of stuff. He said, those people don't know what they're putting in there. And this is just his opinion. This is just my opinion. He said, however, one cool thing that he's learning about is putting in actually synthetic particles that don't have an immune response, but do have an inflammatory response. And that's the cool part about it, is that even someone who's grown up in the allopathic model is thinking about controlled inflammatory reactions and how beneficial they would be. When you marry those to the right set of eccentric exercises and you can remold tissue, that's when you can really have a dramatic effect on these kind of patients. Cool part for ChiroUp subscribers, we've just added a bunch of eccentric exercises and also isometric exercises. There's a lot of times that people can't go through a full range of motion and provide or do any kind of eccentric exercises. Take them to that painful arc of motion and do some isometrics. It will help decrease their pain, whether it's for the hamstrings, the lateral elbow, or the supraspinatus. Consider isometric strengthening as the beginning part of your rehab program. Once again, if you have any questions, Brandon@ChiroUp.com. You can always contact us. If it's a question that can be answered, we're going to hopefully get it done within one day. If it's something that we need some help on, we have a bunch of resources and people at our disposal. We'll try to find the answer as soon as we can. Once again, thank you for allowing us to do what we do. This is truly something that we're passionate about. We go out and talk all the time. Some people even return for another one of our talks. In fact, I was just in Vermont. It was a great crowd. Dr. Burleson was just in Florida, another great crowd. I'll be in Kansas City this weekend. If you're in Missouri, you're in Kansas, come see us. It'll be fun. Even if you're not going to the seminar, I think it's in Overland Park, I'm not quite sure. Even if you're not there, get a hold of me. I'll be in Kansas City. We'll get together And once again, thank you for allowing us to do this kind of stuff. It's what gets us up in the morning and hopefully change the perception of our profession. Thanks.